The case that I have for you today, this is a 64-year-old lady who was initially treated elsewhere and came to me in follow-up. She has a significant vascular history. In 2012, she had an aortobifemoral bypass for bilateral lower extremity rest pain. And then subsequent to that procedure the same year, she had additional treatments which included bilateral lower extremity pan stenting of her SFAs. This was kind of the pre-paclitaxel treatment algorithm at a lot of centers. And so she had self-expanding nitinol stents that were placed in her bilateral SFAs. And then subsequent to that, had some further vascular disease. So she had a TIA, was found to have a high-grade brachiocephalic stenosis, which was treated with a Viabond stent graft that same year. Past medical history is significant for hypertension, hyperlipidemia. She works as a gas station attendant night shift and is just on her feet all the time, even at this age, really not slowing down at all. And unfortunately, secondary to that, she really doesn't control her diabetes very well. So her hemoglobin A1C is 11.4. Relevant medications, apart from her diabetes meds, include aspirin, clopidogrel, and then high-intensity statin. So now she comes in, she's being routinely surveilled, and she comes in with 1 month of dorsal toe ulcers on her left foot and rest pain. She has bilateral non-palpable monophasic DP and PT signals, shallow ulceration on the dorsal aspect of the left third and fourth toes, and then palpable 2+ radial and brachial pulses in the bilateral upper extremities. We started with some non-invasive imaging. She's been surveilled, like I said, on an annual basis within our office. And her prior duplexes demonstrated stable elevated velocities in the bilateral SFA. But now we have progression at this most recent follow-up, more so on the left side. So if you look at the individual numbers, you'll see that on the left side, she's progressed from about 275 a year ago now to 522. And on the right side, we have a kind of a persistent marked elevation in her velocity. And when you look back at the grayscale imaging, you see that actually on the right side, the proximal aspect of the SFA stent kind of covers the origin of the profunda, so I think you're seeing a lot of velocity elevations in that region because of some turbulence. ABIs were 0.6 range, and you can see some blunted waveforms distally there. So we started with a CT angiogram. You see she's got patent bilateral aortobifemoral bypass graft, and as you approach the SFAs, you see more so on the left side, she has significant in-stent stenosis with soft atheromatous plaque versus intimal hyperplasia there going the length of her stent. So just in summary, CTA shows bilateral severe in-stent stenosis of the bilateral lower extremities. She has hostile groins from a surgical standpoint, as well as the fact that these stents encroach into the proximal, into the distal common femoral, more so on the right. She has 3-vessel runoff, and then on the left, on the affected side, she has single-vessel runoff. So we elected to treat this patient via brachial access. We did a bilateral SFA rotational front-cutting atherectomy with distal embolic protection and 2.2 millimeter Phoenix atherectomy catheter, and we used a detachable ambo shield filter for distal embolic protection. Followed that up with 5 millimeter angioscope balloon and then 5 millimeter DCB. So just going over some of the images. If you look, I tend to use kind of dilute strength contrast, so you have to look a little closer, but I'll blow this one up for you. You can see on the left side, she's got severe in-stent stenosis throughout the proximal SFA. And then going down to the mid portion, you can see filling of the above knee popliteal and distal SFA via the perineal collaterals, and then kind of late filling of that distal SFA portion. So after the initial pass, 2 passes of the 2.2 millimeter atherectomy catheter, you can see some significant luminal gain there, although obviously residual stenosis, and then completion after the balloon angioplasty. So just of note, it's interesting, we have nice luminal gain throughout, but we have this kind of proximal residual narrowing, which is relatively, not really tapering, kind of just consistent throughout about a 2 centimeter length. And we hit this again with a balloon, but given the fact that we did not use a directional atherectomy catheter in the presence of the bare stents, the question is whether or not anything else could have been done in this particular scenario. I think looking over what we've talked about in the conference here, one of the things would be utilization of IVUS to try to visualize how much stenosis is actually left at this area. And then if you look now at her runoff, you can see nice brisk runoff now with preferential filling of her normal anatomy through the SFA. The right leg, much more focal stenosis, but again, given access complications, you kind of want to treat while you're there, I think. So she had this focal stenosis. We treated that with atherectomy, and you can see some tandem stenoses distally of less severity. And again, after atherectomy and angioplasty, you can see nice resolution of the stenosis there. So in follow-up, she was discharged on post-op day 1. She had palpable DP pulses, and then on her return, she had significant improvement in her ABIs. She had healed her toe ulcers, and now you see a nice brisk upstroke in that waveform on the toes. Unfortunately, she had to stop her clopidogrel at 4 months because she developed symptomatic anemia, and she ended up having a small bowel AVM, and despite kind of multiple efforts to do some intervention so we could put her back on the dual antiplatelets, we had to keep her just on aspirin for a while. She had progression of her left SFA stent velocity, so I elected, it was about a doubling over the course of about 3 months, and I elected to take her back and retreat that. Interestingly, that proximal portion looks fine, and that really wasn't where the stenosis was. In fact, if you look there, you can see this is kind of a disparate area in that mid SFA that wasn't present on the first go-round. So we did a similar procedure, which is now ballooning to 6 millimeters. And so now she's out to 9 months, and she hasn't had any other residual issues. She's now back on Plavix without any bleeding episodes. So just looking at this particular device for atherectomy, in this short and midterm trial, this was 75% of patients with a Rutherford classification of 3 or greater. 42% of the patients within the trial were treated with single vessel runoff. Pretty short lesions within this particular group, and a small minority of the operators used a distal embolic protection device. Final percent stenosis after adjunctive treatment was about 10%, with 1% symptomatic emboli and 4% need for bailout intervention. And at 6-month follow-up, 80% maintained improvement in the Rutherford classification with about 12% clinical target lesion revascularization. So again, thank you for the opportunity, and look forward to any commentary.